The following presentation was recorded at the 2017 ANZIC's Safety and Quality Conference.
Yes, I am an emergency physician at Westmead Hospital, and I totally share the views that were shared before. There is a lot of pressure on us to get patients out of the emergency department quickly enough, and I also worked with the CEC on the sepsis skill pathways, which we've implemented across New South Wales. So I'm going to share some of the experiences. It's not a pure data exercise like a lot of talks, but it's more about the implementation science. So the objectives of the talk today is to talk about sepsis screening algorithms, the implementation of a sepsis skills program or a quality initiative, the issues with SIRS, organ dysfunction and the definitions of sepsis, and how that's going to impact our performance. Algorithm performance versus clinician gestalt, just like we previously spoke about, and the whole issue about implementation science and learning systems. We all know that the diagnosis of sepsis can be challenging, and recently there's been a change of moving away from defining sepsis from SIRS as a response system to organ dysfunction approach. As a ED clinician, it makes it even worse, because I go, well, how do I predict who's got organ dysfunction? It's easy when you say, oh, the pulse is wrong, the respiratory rate is wrong, the blood pressure is low. That's easier to gauge than when actually look at organ dysfunction as such, especially when patients walk in and we don't know what their baseline status is. Sepsis in general, I find, especially in the ED, is quite challenging, because unlike coronary artery disease, you could have a blocked coronary artery, you get chest pain, you get ECG changes easy. Whereas sepsis, we all know, is multi-pathogen, multiple host factors, multiple environmental factors. So that's why the SIRS has been difficult, and I'm sure organ dysfunction will be equally as difficult to implement, especially when we are talking about what is an existing organ dysfunction versus new organ dysfunction, and totally discounts the tissue dysfunction markers, where a lot of research currently is focusing. By the time a patient has got acute renal failure and an organ dysfunction, a SOFA score of 2, there's lots of irreparable damage already done to that patient. So are there better systems in place which can pick these patients earlier? And then the whole system about, in general, talking about screening, selective screening, which is picking up the highest risk patients, and then multimodal screening, which is more commonly used in sepsis. So, as we know, in ED, the sepsis skill program was set up as a screening tool, and the first step on it was to pick up the high-risk patients. Now, we do know that historically there are features which can pick the patients as for SIRS, signs and symptoms, immunocompromised, recent surgery, high-risk features for sepsis, and then flag it on a system. These are the patients who've got higher risk for having sepsis. Fortunately for ED, it's an easier piece of work than what it is in the wards, because it gets all messed up. At least we've got a single triage where all the patients come in from, and we can get those history factors in, and then we can start from there. The SIRS-based program led by the CEC was based on the Between the Flags program, and that is one of the reasons why the SIRS criteria within the sepsis skills program are different to the Surviving Sepsis Campaign SIRS values. And we are not the only ones who are different. As you can see, the pulse is more than 120, and whereas the surviving sepsis is more than 90. The temperature guidelines are slightly different. But when we looked at international sites, pretty much everyone had a slight variation on their SIRS variables and cutoff values. So we're not alone in that. And it all depends on their underlying rapid response system criteria, and I believe that needs to be standard across. You can't tell a nurse on the floor, if the pulse is 90, then it's a met call if you think it's suspected infection. And if it's not infection, it's 120. You can't apply two different rules for the deteriorating patient. So we had to adopt the CEC pathway with the BTF criteria embedded in them. This is a diagram of the two-stage screening process which we were using. It's available online, just Google CEC Sepsis Skills Pathway. So when we had launched this at Westmead Hospital, we had education material, we gave some antibiotic prescribing cards, we had sepsis trolleys, and we also had a triage categorization of patients being called as sepsis. We did a slight variation on the implementation than other sites, is we actually used the AMR as well. One of the key differences at Westmead was that we allowed clinicians to place clinical suspected sepsis patients on the sepsis pathway. So we actually asked them to select patients at triage. The triage nurse could do down that column, select a patient on the sepsis pathway, and then they would be tracked on the system as a sepsis bomb, as you can see on the column there. The clinicians in the back end as well were able to put patients onto the sepsis pathway, even if they didn't meet the SIRS criteria or the cutoff values for the program. And then we had a reporting structure where you can see that injection symbol, so the nurses would click when they did the time to antibiotics, first antibiotics. Now, ideally, hopefully once we have full EMR implementation, the first antibiotic dose will be automatically clicked through eMeds program. But what I'm trying to suggest is that people don't have to wait for the full EMR eMeds implementation to start doing reporting on quality projects. I find this around all states. They go, well, why do this now? It'll come in the next 10 years. We don't know when it'll come, but you need to start reporting and collecting data on patients straight away. What it let us do was basically every week I could pull out reports from my AMR, track how my patients were going on the sepsis pathway, what were the time to antibiotics, and actually tackle it live. I can actually do live reporting on my phone right now for Westmead on my sepsis performance in my department. We don't have eMeds. All we've got is a eMed. We've just developed a pathway locally to track patients. After the implementation, one of the key things we saw was that there was an initial spike, and I think that was possibly because of increased reporting. And we've stayed under the guideline for a long time. This is from 2014 slides, because after that we stopped direct reporting to the CEC website. One of the key things about the CEC Sepsis Skills program was that it was an embedded quality research initiative. I don't know, I think Tony Burrell's vision was for it to be a quality research initiative, so a sepsis register was set up, which included self-reported, online portal reported from more than 100 New South Wales sites. At our site, we did that, plus we did a retrospective review of everyone who was put on the sepsis pathway. But like I pointed out, we also collected the patients who were flagged as clinical suspicion of sepsis. This paper was published by the group from CEC and definitely showed a reduction in mortality and also the increased measurements and abundant implementation across the state in New South Wales. We've also used the sepsis register to actually look at lactate cutoffs and found that a lactate cutoff of more than 2 is currently under review with BMJ for the risk of mortality and ICU admission more than 10%. So whilst we are not saying we can't change the BTF criteria, but we can educate clinicians with patients with suspected infection. And you'll see there's already 3 more articles out there in reputed journals recently about this cutoff. We've also managed to change the time target to 120 minutes for patients with severe sepsis. In septic shock, we've asked them to still be immediate antibiotics because the trends weren't showing any reflection on the outcomes as such. Like pointed out earlier, we did a validation of all the SIRS algorithm across, and there is no perfect algorithm to date to be compared to, but we published on the algorithms as well. For this topic, I thought it'd be good to bring it back to clinician suspicion, and we thought we did retrospective chart reviews and notes reviews on over 1,250 patients, and after that I gave up. Because I think it's still a large cohort, and we had about 529 patients who didn't meet the BTF SIRS-2 criteria, but they had risk factors in their admission as well. When you compared the clinical suspicion cohort, they had a low risk for ICU admission, they had a low risk for all-cause hospital mortality. But when you looked at their organ dysfunction, 1 in 3 still had SOFA sepsis according to criteria. when I went back and did the report on the EMR, there's 4,500 patients who had flagged. I'm not doing that much case reviews, but what we're going to do is we've already got all their data linkage data, and now I've got a PhD student sitting on it and sifting through it. So the key question here is not to just capture what you do, but also capture the boundaries and the blurred edges around it. And that's how you develop further. We're going to use the major data set to do all these things, but we've already shared our data across Australian sites. We've done a validation of the QSOFA across 30,000 patients in Australian EDs. We've also shown that addition of lactate to the QSOFA improves its sensitivity. This is on over 30,000 patients across Australian EDs. So what we started off as a quality program is actually got a big thriving research footprint now. But what I wanted to bring it all back to was this. I think Australia is in an interesting phase where the implementation of data systems is occurring parallel, and I think we need to start capturing data more in a structured manner and also allow for that clinical variation to be captured. So even if you capture 10% patients which would have normally missed by these pathways, we can learn from those and say, how do we change our current pathways to try and meet more of these patients who lie on the edges? And I think as clinicians, and when you talk about senior clinicians, they were picking 1 in 3 sepsis patients just by looking at them. So and this one was, they had to flag it themselves. This was not from a retrospective chart review. So if they're picking it, then what is it that they're picking at? If we know those patient groups, and then we can look back and alter our criteria based on that, that's actually truly developing learning systems locally. The other thing is to track the changes and learn and keep the iteration cycle going. Always learn from your near misses and the confidence intervals. And the key thing is, if we don't tell the technology what to do for us, it will tell us what it wants us to do. So we'll end up with not a clinical support system, but a clinical automated system. So I really think clinicians need to start pushing themselves out there, and get out from the box that technology is the enemy of anything, but start working with it to inform future systems. Thank you.